Good morning, everyone. Good afternoon. My name is Joris van Montfrans. I'm a pediatrician in Utrecht in the Netherlands, and I'm very happy to present for you the Dutch ADA2 deficiency latest findings. And I do this on behalf of the team of all the Dutch ADA2 physicians. And I wanted to express special thanks to Valerie Andriessen, who has helped me a lot with this presentation. So in Holland, we have an ADA2 deficiency cohort of now 25 known patients, and this is including one heterozygous symptomatic individual. And in this presentation, I will discuss with you the findings in 19 of these 25 patients, and this includes this one heterozygous individual. So what we have seen the last years in this group of patients is the normal presentation of ADA2 deficiency, as you can see in the percentages that are under here. So we've seen strokes in about 1/3 of all the patients. We've seen the livedo reticularis. We've seen the recurrent infection in more than half of the patients, the neutropenia, the hypogammaglobulinemia. And the bone marrow failure we have seen in about 21% of all patients. Now, if we further look into baseline characteristics, the mean current age of our cohort of patients is 31 years. The mean age at presentation, at first presentation, was 3 years, with a range between 0 and 8 years. And we have a slight predominance of males in the cohort. And if we look at genetics, we actually see that at the beginning of our investigations into ADA2 deficiency, we only found the R169Q mutation in 100% of the patients, but we now have seen other mutations as well, as you can see below in this graph. So the R169Q mutation is still the leading mutation in the Netherlands. We still believe that there is a founder effect in the Northern European countries, but it is not the only mutation that we see at this moment. We've seen some very rare manifestations of ADA2 deficiency. For example, one girl was diagnosed with acute myeloid leukemia with chloroma, which at the end actually appeared to be ADA2 deficiency. We've seen 2 patients with large granular lymphocyte T-cell leukemia. We've seen a patient with congenital chylothorax, one schwannoma that actually appeared after transplant, and one patient was very unlucky to be only diagnosed after he passed away. This was a man that was well into his 40s. He was diagnosed with sarcoidosis and neutropenia. He developed a fatal bout of HLH, and only after he passed away the diagnosis was made, which helped us in finding other patients in his family. Now, if we look at the R169Q mutation versus other mutations, we see that we find actually more strokes in this population as compared to the other mutations. We also find more hepatosplenomegaly and a bit more infections, and we see more hypogammaglobulinemia. So the phenotype in our country seems to be associated both with stroke and the immune deficiency phenotype. We see here, if we further zoom into this, that these differences are marked clearly. Now, in the last year, 2019, we published a paper about a Behçet disease-like phenotype that was actually found in patients with ADA2 deficiency. So we identified in the Netherlands 4 patients, and in Turkey 2 patients with a splice site mutation, as described here in the heading of this paper, published by Dr. Van Wel. 3 families, 6 patients, they all carried the same homozygous splice site mutation. And 2 of those 6 patients actually had very much Behçet-like phenotype with severe aphthous stomatitis, genital ulcers, and/or ulcerative gut lesions. We looked into aberrant splicing, whether that actually would be the explanation for the differences in the variability of the phenotype, but we could not find that differences in the mutant RNA transcript could be linked to the differences in the clinical phenotype. In the first paper that we published in 2016, we found that residual ADA2 activity actually seems to be associated with the risk for stroke. So here you see on the left side the patients that had stroke and they have very low ADA2 activity levels. This is all before they have started on therapy, versus the patients that had no stroke. They had higher residual levels of ADA2 deficiency. We repeated this investigation, and we actually now in 19 patients see that we still have a marginally statistically significant difference between the patients who had stroke versus the patients who did not have stroke. And it seems to be, at least in our findings, that the lower the level of ADA2 enzyme activity, the higher the chance for stroke is. We also followed ADA2 activity levels over time, and we tried to see if ADA2 levels actually are correlated to the use of TNF blocking agents. Now, what you see here is that it seems very much that ADA2 deficiency levels go down after the initiation of TNF blocking agents. But I must say that some of the patients here in the graph did not start on TNF blocking agents, others actually did. So for 3 patients, we find that when they had residual ADA2 activity levels, after they have started on TNF blockers, their activity levels really dropped to 0,0. But it was not yet statistically significant. So we have the feeling that there's a trend towards lower ADA2 deficiency levels after the start of TNF blockers. Now, this is for treatment in all the patients in the Netherlands. All patients are on any type of medication. However, not all patients are on TNF blockers. 13 out of the 19 patients we evaluated are on TNF blockers. 2 out of the patients have undergone hematopoietic stem cell transplantation. And if you zoom in here, you can see that 1 patient is actually on IL-1 blocker, anakinra, and 2 patients are on G-CSF, narbogen. So these patients actually have been on TNF blockers, but they developed severe infections. That was the reason that they stopped actually with the TNF blockers. So they have the phenotype more of the bone marrow failure. That's why they get the G-CSF, and they are both awaiting stem cell transplantation. And then here you see the 2 patients that have actually undergone transplantation. So in Holland, we have the luxury that all patients have access to all the biological and other medications that they need. What about transplant for ADA2 deficiency? So 2 patients underwent transplant in Holland so far, 1 for refractory pure red cell aplasia and 1 for pancytopenia and B-cell lymphoma after the treatment for the presumed AML. So both these patients are well, although 1 patient developed a schwannoma of the ischiatic nerve after transplant for which he was operated. 2 patients are scheduled for transplantation. Both have recurrent infection. Both have the phenotype with severe neutropenia. And 1 of the patients actually has already had a B-cell related lymphoma. And the other patient has a malignancy as well. So he has refractory T-cell mediated large granuloma cell type. What about the incidence of the R169Q mutation in the Netherlands? So here on top, based on the GNOMAD database, you can see that in Finland, the allele count of this specific mutation is rather high, 0.2%. And we thought eventually that in the Netherlands this was the same. However, we think that there is a founder effect, but we also think that the incidence of this mutation is a bit higher in the Netherlands than in the other Finnish countries. So, but if we calculate how many patients we would expect given this incidence rate, then we should be able to find about 60 patients in the Netherlands with this mutation. We have found about 12 of them. So that means actually that there are still undiagnosed patients, or there are individuals that are asymptomatic. Now, at the end of my presentation, I wanted to focus on the fact that we will have a Dutch ADA2 deficiency chapter. Here you see on the right side two of the organizers of this chapter, Linda and Sanne, who I'd like to thank as well. So the 25 patients actually are now organized in one group. They consult with the doctors, and we are very much on the same level. We mail each other on a first name base, and by doing this, we actually have now made a plan for a meeting online 1 week after this online meeting. And so on the 27th of November, we will actually have a feedback meeting for all the patients in which we will discuss all the findings of this conference. So the take-home messages are here. I have to do it quickly because of the time. We have now 25 patients, half of them carrying the R169Q mutation. We reported the Behçet-like phenotype. We confirmed the relation that we found earlier between residual ADA2 activity levels and the risk for stroke. And in our country, 4 out of 25 patients either underwent transplantation or are scheduled to do so. Now, I come to the last slide. Many thanks to all the Dutch ADA2 deficiency patients, to Valerie Andriessen for helping us out with organizing the day and all these data, to Elisabeth Legger and Jolanda Menger and the Eurofever registry, and the folks who helped us in the lab, the physicians, the genetics department, and of course, Chip Chambers and the team of the ADA2 Deficiency Foundation. Thank you very much.